Hi everyone, my name is Sophia Flesch and I am excited to present my proposal for a study that assesses the effect of magnesium supplementation and the progression of coronary artery disease in type 2 diabetics. Magnesium is the fourth most abundant mineral in the human body and plays several important physiological functions. Magnesium is a cofactor in glucose metabolism as well as protein production and DNA-RNA synthesis. Magnesium is readily available and found in foods such as dark leafy green vegetables, nuts, legumes, and whole grain cereals. Although it's readily available in these dietary sources, as high as 15% of the population is deficient. Absorbed in the small intestine, inadequate intake of magnesium can depend on the body's magnesium status at baseline. Adequate intake of magnesium is also associated with a decreased risk of chronic diseases and all-cause mortality. Although toxicity is rare, it can be combated with appropriately functioning kidneys. Unhealthy lifestyles are a key contributor to the increase in non-communicable diseases, or NCDs. As these NCDs increase, the cost of healthcare also increases. Therefore, medical practitioners are required to find cost-effective interventions that will improve the health outcomes of their patients. Second to diet, supplementation is economical and definitely a modifiable risk factor for NCDs. Therefore, the purpose of this proposed study is to examine the relationship between magnesium supplementation and the progression of coronary artery disease, or CAD, in those who already present with an NCD, such as type 2 diabetics. Specifically, this proposal addresses the research question of, does magnesium supplementation prevent the progression of coronary artery disease in middle-aged type 2 diabetics? This question will be evaluated by examining the heart's perfusion of blood in a sample population of middle-aged diabetic adults prior, during, and following the study. For the purpose of this study, magnesium supplementation will be defined as a 500 milligram oral magnesium supplement. Middle age will be defined as ages 45 through 65, which is the group that's most likely to develop type 2 diabetes. Diabetics are then also twice as likely to develop heart disease, such as coronary artery disease. Through a literature review via Google Scholar and PubMed of just scholarly articles, there has been significant research published on magnesium, coronary artery disease, type 2 diabetics, and diabetes, and the standard of care set forth by both the American Heart Association and the American Diabetes Association. In regards to magnesium, numerous clinical trials have shown the benefits of consuming magnesium supplementation for at least 4 months or more, and include increasing bone marrow density, improved insulin sensitivity, and blood glucose control. There was a positive change in blood pressure and improved insomnia. Conversely, low serum magnesium was associated with a higher risk of cardiovascular disease, hypertension, type 2 diabetes, increased insulin resistance, and sudden cardiac death. Recently, different cohort and randomization studies have indicated that the intestinal absorption of magnesium depends on the body's magnesium status at baseline, as well as their genetic predisposition of serum magnesium. Coronary artery disease, or CAD, is the most common type of heart disease and is the current leading cause of death in both males and females. CAD is considered a non-communicable disease, and it occurs when an inadequate amount of blood is flowing to the heart due to plaque buildup or calcium buildup. This artery calcification can lead to angina or chest pain, a heart attack, an arrhythmia, or even heart failure. The American Heart Association guidelines state that a lifestyle that incorporates good nutrition, weight management, and physical activity plays a major role in the prevention and treatment of progression and overall coronary artery disease diagnosis. Physical activity, according to the AHA standard of care, is defined as 150 minutes per week of moderate intensity aerobic exercise or 75 minutes a week of vigorous aerobic activity. The diet recommendations include an increased amount of fruit and vegetable variety, emphasis on whole grains, low-fat dairy product, nuts, legumes, skinless poultry and fish to combat the increased sodium, and non-tropical vegetable oils to control the amount of saturated fat. Weight management includes watching the portion controls, drinking alcohol only in moderation, limiting your added sugars, and the stopping of all smoking. Type 2 diabetes affects more than 9% of the current U.S. population and is also considered an NCD. When you have diabetes, the body either resists insulin's effect or doesn't produce enough insulin to break down glucose. Several complications can arise with diabetes, including an increased risk of cardiovascular disease, nerve damage, kidney damage, and Alzheimer's disease. The American Diabetes Association, or ADA, also outlines a standard of care that is very similar to the American Heart Association standard of care in terms of lifestyle modifications: physical activity, weight loss, diet, and the cessation of all tobacco use. Nutritionally, the ADA standard of care explains that there are no clear benefits to the use of dietary supplements in diabetes management and recommends a Mediterranean diet above all. This is despite the effects that magnesium has on blood glucose control and insulin sensitivity, as discussed in previous slides. Given these emerging themes in the literature, the research moving forward seeks to explore magnesium's effect on coronary artery calcification. Therefore, the goal of this study is to reject the following null hypothesis: that magnesium supplementation will not prevent the progression of coronary artery disease in middle-aged type 2 diabetics. Research will take place at the University of Michigan Health System's main medical building in Ann Arbor, Michigan, and their corresponding cardiology clinic. Participants will be recruited via personal or peer referral, or if they're recommended by their healthcare provider. Inclusion criteria includes middle-aged adults, male or female, that are type 2 diabetic, non-smokers, have immediate or intermediate or high probability of coronary artery disease, and have absence of medical devices in the body unless they're considered MRI safe. Exclusion criteria are those that do not meet the inclusion criteria, so they are either smokers or they have previous history of heart disease, they're non-diabetic or type 1 diabetic, and if they have any current alcohol and or drug abuse. Initial screening for participants will include a CT scan to determine a CAC score, or coronary artery calcification score, to determine their baseline. Total cholesterol, LDL cholesterol, HDL cholesterol, blood pressure, serum magnesium, hemoglobin A1C, and fasting blood glucose will also be noted and taken for individual baseline purposes. Signature on a written informed consent will provide willingness to participate in the study. Using a G-power calculation of medium effect size, an error of probability of 0.05, an estimated power of 0.95. The minimum population required for this study to be statistically significant is 210. This study is of experimental design and uses quantitative analysis. The duration of the study is 5 years, and participants will be randomly assigned into 2 groups: control or intervention. The study is randomized and double-blind, meaning that the researchers providing the supplement will not know who is in the control group and who is in the intervention group. The control group will receive a daily placebo pill, while the intervention group will receive a daily dose of 500 milligrams of oral magnesium supplementation. For the duration of the study, a radiologist employed by the University of Michigan will administer an MRI biannually to determine the amount of heart perfusion and calcification to the left main coronary artery. During these biannual visits, serum magnesium, hemoglobin A1C will also be taken to ensure that the study is not interfering with the patient's ability to manage their diabetes, as well as to ensure that their magnesium status remains adequate. All physician notes, lab values, and imaging will be kept on a separate password-protected EMR server to ensure confidentiality. 1 out of 6 registered dietitian researchers will randomly assign 6-digit participant identification numbers via simple randomization. This one registered dietitian researcher will also have access to which participant ID numbers are assigned to the control or intervention groups and their corresponding data. The last biannual visit will also include a CT scan to determine the calcification of the arteries score, just as we did during the initial screening process. Once the data is compiled, at the end of the study, a statistician will help complete the statistical analysis tests to determine reliability and validity. A chi-squared analysis will test the difference between the control and intervention group, while descriptive statistics will be used to determine and describe the populations of both groups. Data will also be analyzed using an independent t-test to see if there's statistical difference between two group means for their calcium artery score. MRI imaging data will also be analyzed by the team of 6 registered dietitian researchers and 10 cardiologists and radiologists to establish the amount of heart perfusion and calcification that occurred during the duration of the study. The anticipated findings of the study will reject the null hypothesis and showcase that 500 milligrams of magnesium supplementation daily will slow the progression of CAD, especially if more than one NCD is present. Enhanced blood glucose control, improved insulin sensitivity, and the prevention of hypomagnesemia will also be anticipated. However, with these anticipated results, there are some factors that need to be considered. For example, the estrogen level of the female participants. During menopause, estrogen levels decrease and females lose a lot of estrogen's cardiac protective roles and benefits. The amount of artery calcification of subjects prior to the study is also important to eliminate potential bias. Furthermore, patients' serum magnesium level at baseline also need to be considered, as it influences magnesium's intestinal absorption. It is also important to note any existence of placebo effects. For further discussion purposes, there are several strengths in this study. The topic of obtaining adequate magnesium supplementation is overall important, as the prevalence of the deficiency is increasing in society. This study also builds upon existing research set forth by the American Heart Association and American Diabetes Association, and has the potential to provide cost-effective ideas and significant research for the future of healthcare. There are a few limitations of the study, as it is expensive and requires a long time commitment of its participants. There is also a high number of participants required for this study to be statistically significant. Despite these limitations, this study warrants further opportunities, including the revision of the American Heart Association and American Diabetes Association standard of care to include magnesium supplementation in its recommendations for heart disease and diabetes. Since this study focuses on middle-aged adults, there is also further research warranted and needed on the effects of magnesium supplementation on other age groups, such as young adults or the elderly. Here are my references, and this concludes the summary of my research proposal. I thank you for your time, and I really look forward to your feedback.